Alrighty, just want to make sure that we have enough time to get through everyone's presentation and have a robust Q&A. So I'm going to kick things off. Good afternoon, everyone, or good evening, depending on where you are. Thank you so much for being here. We really appreciate you taking the time out of your busy day to come and learn a little bit about germline predispositions to hematologic malignancy. I'm Katrine Erickson. I am the Executive Director of the RUNX1 Research Program. We are a nonprofit organization dedicated to patients with RUNX1 familial platelet disorder, which is a type of inherited predisposition to hematologic malignancy. The work we do is really through funding research. We are building an engaged and empowered patient community, and we're also trying to facilitate as best we can collaboration across the healthcare ecosystem with one goal in mind, and that is to develop treatments that could prevent the onset of blood cancer. On behalf of RRP, I want to thank my co-organizers, Drs. Ross Levine and Uli Steidl. We really appreciate them taking the time to help me build this. We've built a 2-day program, 1 hour today and 1 hour tomorrow. So if you're here with us today, please consider joining us tomorrow as well at the same time. I'd like to take a little bit of time to introduce Drs. Ross Levine and Steidl, who are true experts in the field. Dr. Levine is a physician scientist whose research goals are to improve our understanding of the genetic basis of myeloid malignancies, with the ultimate goal of using that knowledge to improve treatments for patients with myeloid malignancies. He is the director of the Memorial Sloan Kettering Center for Hematologic Malignancies, the Lawrence Joseph Deneen Chair in Leukemia Research, a member of the Human Oncology and Pathogenesis Program, and an attending physician at Memorial Sloan Kettering Cancer Center. Dr. Steidl is also a physician scientist whose research is focused on defining the critical mechanisms of hematopoietic stem cells and their formation, underlying the formation of pre-leukemic stem cells as well as leukemic stem cells. Dr. Steidl is a professor of the Department of Cell Biology as well as the Department of Medicine at Albert Einstein College of Medicine. He is the Diane and Arthur B. Belfer Faculty Scholar in Cancer Research, the leader of the Stem Cell Differentiation and Cancer Program at Albert Einstein, as well as the director of Stem Cell Isolation and Xenotransplantation at the Institute at Albert Einstein. Drs. Levine and Steidl have brought together a wonderful group of presenters today, and we're grateful for their relationship and partnership in building the seminar, really all about raising awareness of these predispositions to hematologic malignancy. Before I introduce our first speaker, I just wanted to give you a little bit of information about how this will go. We'll have both presenters today speak back to back, and then we'll host a Q&A session where Dr. Uli Steidl will be the moderator. So as you start to think of your questions, please make sure that you put those questions in the Q&A icon, which is at the bottom of your screen, or I guess it could be at the top, depending. And refrain from using the chat function if possible. And with that, I will introduce the first speaker. Our first speaker is Dr. Michael Walsh. He is a pediatrician, a geneticist, as well as a hematologist oncologist. He treats children with cancer and cares for families with predispositions to cancer. He is a member of the Niehaus Center for Inherited Cancer Genomics. He's a member of the Department of Pediatrics and the clinical genetics team at Memorial Sloan Kettering Cancer Center. He will be speaking to us about the history of inherited predispositions to hematologic malignancies, their prevalence, and the importance of accurate diagnosis. And with that, I'll turn it over to you.
Thanks very much, and I appreciate the opportunity to speak today. It's a real treat to speak to this audience, and thanks for organizing this, Katrin and Ross and company. I've enjoyed putting this together because from the genetic side of things, it's always nice to go back and look at the history of any of the different conditions we care for and the different syndromes and where they have their roots and how things have evolved over time and how our understanding has really gone from standing on top of a building, looking down and with a gross description to really getting down on the street and looking more carefully in this sense, really molecularly looking at the diseases we're caring for. So today I'll be discussing the history of inherited predisposition to hematologic malignancies, prevalence, which we're still really getting a sense of as we're understanding these syndromes more and we're doing more and more sequencing, and how we're beginning to understand why it's important to identify patients with a heritable underpinning. So in the last 15 to 20 years, of course, there's been an explosion of next generation sequencing. And with that, we've been able to better understand leukemia, and at the same time realize that when we're evaluating patients with leukemia, it can be difficult to identify a predisposition because of the sample source we may be looking at. And as a result, we've gotten more savvy over the last few years of keeping this in mind and using alternative tissue sources to try to understand when people may be born with a predisposition that we identify through an alternative tissue sample. So in the last few years, there have been papers describing with some amount of patients, but not the number we would hope, the frequency of individuals with a predisposition to cancer with different leukemias. And these studies have all been biased in different ways. A couple of studies have been done in the US as well as abroad. A couple ones to note are just a Finnish study which looked at 84 consecutive patients, revealing about a 10% pickup rate of individuals with mutations in cancer predisposing leukemia genes. And a study a number of years ago done at St. Jude was similar in showing about a 5% pickup rate for children with ALL, whereas most of the studies in the adult world have been done with AML, or acute myeloid leukemia. And I'll come back. Yep.
I just want to make sure you share your slides.
I'm sorry. Sorry about that. I thought they were on my screen. It looks as though I'm sharing them. I beg your pardon. Sorry about that.
No problem.
There we go. Sorry. Can you see them now?
Yes, they're coming up. Yep. We see them.
Okay. I'm sorry about that. All right. So just going back a second. So the first slide was just illustrating a few of the next generation sequencing studies that have occurred in the last few years, which have added to our understanding of leukemia in both the adult and pediatric worlds. And a couple of references to recent studies showing frequencies of cancer predisposition in leukemia populations, and specifically in the adult side for patients with acute myeloid leukemia, and in the pediatric world with a bias of acute lymphoblastic leukemia patients, each with percentages between 5 to 10% pickups for patients in these studies. And I'll get into this in more detail and talk and show why there's limitations to both of these studies. So as we think about leukemia, we break it up into the myeloid and lymphoid predispositions. And AML, of course, is more common than any of the other leukemias that we see and treat. Acute myeloid leukemia occurring mostly in the adult population, being the most frequent leukemia that's seen in the field. And whereas in pediatrics, acute lymphoblastic leukemia is the more common cancer type we see. And with acute myeloid leukemia, there is a significant pickup in the percentage of patients diagnosed with this after the age of 65, which makes one wonder when patients present at a younger age than that, if there might be a predisposition. And as time has gone by, we've learned, particularly with RUNX and CBP alpha, that these patients do tend to present at a younger age when they have a heritable predisposition. So in terms of the history of all of this and going back over time, the description for many of the leukemia predisposition syndromes for the overtly syndromic conditions which have a predisposition for different leukemias goes back well over 100 years. So Down syndrome describes one of the most common leukemia predisposition syndromes, which can predispose to both AML and ALL. Fanconi in the 30s described children with bone marrow failure, which predisposes to leukemia. Von Recklinghausen with neurofibromatosis over 100 years ago also described a leukemia predisposition syndrome, specifically juvenile myelomonocytic leukemia being part of that cancer predisposition syndrome, as well as Noonan in the middle of the last century, a cardiologist we're describing another RASopathy with a cancer predisposition. Specific familial leukemias without necessarily the overt stigmata of some of the classic cancer predisposition syndromes that we think about in pediatrics were described right around the end of the Second World War in 1944 with a couple family members described with leukemia. In the 70s, as the Li-Fraumeni syndrome population, in 60s and 70s, as that population was being clinically classified, leukemia came to be noted as part of that cancer predisposition syndrome. In the end of the 20th century, or 1999, RUNX1 was described as an AML predisposing syndrome. And then in the last 20 years, with the explosion of next generation sequencing, we've identified a number of cancer predisposition genes as part of the sequencing that's been taking place. So leukemia can be thought of in different ways in terms of the heritability of it. It can be thought of based on the leukemia type that we see the most of, so ALL predominant or AML predominant. It can be related to a syndrome with multiple cancers individuals are predisposed to, or it can be part of an overtly syndromic cancer predisposition syndrome. And on the right of the slide are a number of the cancer predisposition syndromes associated with leukemia, including both those predisposing to AML and ALL. CLL and CML are less well understood in terms of the cancer predispositions to those syndromes, and there's still a lot to be learned. For the lymphomas, or the other type of lymphoid disease, we don't tend to see as much in terms of predisposition outside of those individuals with an inherent immunodeficiency identified in the early years of life. However, there are some, and some of the autosomal recessive genes, when they're inherited in the heterozygous form, do carry with them a small odds risk ratio. And as was recently described in the last year or so, there is an enrichment of individuals in the young adolescent, young adult age group with non-Hodgkin's lymphoma that carry BRCA2 mutations. So in terms of the cancer predisposition syndrome, as mentioned, one of the first described was Down syndrome, or trisomy 21, which carries with it a 10 to 20-fold increased risk of leukemia. And it specifically predisposes to ALL, AML, and within AML, a very specific subtype, AMKL. And for each of these, there is a significant increased risk in leukemia predisposition. And this has implications in terms of thinking about treatment as well, which I'll mention at the end, and some of the sensitivities that the patients with trisomy 21 have. The RASopathies come with them also a cancer predisposition, specifically to juvenile monocytic leukemia. And they are often recognized clinically because of other clinical characteristics and stigmata individuals may have. Neurofibromatosis, which is the most common of these conditions with a 1 in 3,000 carrier frequency, is one that is diagnosed usually clinically by individuals having 2 of 7 clinical criteria, and is one that is good to be aware of in terms of thinking about if a diagnosis of JMML is made, the potential need for transplant. Noonan syndrome, another RASopathy, is one which also comes with it a predisposition to JMML. And in some types of this, the leukemia predisposition is something that can resolve with time, and is a differentiating factor between it and some of the other JMML occurrences. So Noonan syndrome, as mentioned, was originally described by a pediatric cardiologist. It's not as common as neurofibromatosis, or actually, excuse me, it's about the same as neurofibromatosis. It has an autosomal dominant inheritance pattern similar to NF, and has other clinical manifestations that involve other organs. The picture on the right down at the bottom was a picture of the individual that is reportedly the first individual with Noonan syndrome described, again, many years ago. A point to be made about constitutional mismatch repair deficiency, which is a phenocopy for neurofibromatosis in the sense that individuals can have cafe au lait spots, as well as a predisposition to brain tumors, is that it's important to make a difference in, or diagnose these two conditions molecularly, as it can have an impact on thoughts around therapies. For individuals with constitutional mismatch repair deficiency, which is a cancer predisposition syndrome resulting from biallelic inheritance of mutations in MLH1, MSH2, MSH6, or PMS2, which are known as mismatch repair DNA repair genes. Individuals that have biallelic mutations in these genes universally develop multiple malignancies by the time they hit 20 years of age, and leukemia, it can be one of the types of cancer they develop, both ALL and AML, and it's relevant again for therapeutic purposes, as these individuals have an inability to appropriately repair their DNA given the mismatch repair deficiency, and may require increased dosing of certain antimetabolite therapy. For this population, similar to Lynch syndrome patients in the adult world who are heterozygotes for mutations in these genes who respond to immunotherapy, this has been shown to be of benefit for the solid tumors that patients develop with this diagnosis. However, for AML and ALL, the data has not yet really shown to have the same benefit in the leukemia population that it does for the solid tumor patients with this underlying genetic defect. So there are the overt syndromes that I just mentioned that predispose to different leukemias, usually AML or JMML for the RASopathies, and for Down syndrome, which can Down syndrome predisposes to both. Then there are the bone marrow failure syndromes, which again were described many, many years ago in different clinics than hematologic clinics, based on some of the other clinical manifestations that come with them. And specifically, telomere syndromes and Fanconi anemia are the bone marrow failure syndromes that we probably see the most of, which predispose to AML and MDS. And their diagnostic importance is related to the exquisite therapeutic sensitivities these patients have. And it's important to make this diagnosis, as they don't handle traditional lines of therapy well. So the telomere syndromes are ones that come in different varieties, if you will. And the syndrome was originally described by three dermatologists in the early 1900s, who were observing patients with different skin, tongue, and nail findings. And over time, as these patients were followed, it was realized that many of them had failure of their bone marrow and would go on to develop leukemia. And as time went on and telomerase was discovered, and then the genes that regulate telomerase were discovered, it was realized that many of the patients had mutations in these genes that play a role in the regulation of telomere maintenance, for which the Nobel Prize was awarded a number of years back. So again, the importance for diagnosing these conditions really relates to therapeutic sensitivities, as well as the fact that there are other manifestations of these conditions that can arise later in life, and people should be aware of, particularly pulmonary fibrosis, liver cirrhosis, and other immunodeficiencies. So telomere syndromes are one of the main bone marrow failure syndromes we see. We diagnose them using our clinical assessment, as well as a technique called FlowFish, which measures telomere lengths, and genetic testing and sequencing. Just a point about these types of disorders and the importance of recognizing them. We did a survey of our solid tumor patients at Memorial about a year ago, who for individuals that had undergone sequencing of the TART gene, and we identified a number of patients when we went into their history that had not previously been diagnosed with these disorders, that did have therapeutic sensitivities, and did have other people in the family that had not been diagnosed with a telomere syndrome that had signs of such, and particularly individuals with anemia or thrombocytopenia that have been followed without a diagnosis for some time. Fanconi anemia is the second bone marrow failure syndrome that I wanted to highlight, named after Guido Fanconi, who described 3 boys with low platelet counts in his clinic many years ago. And at this point in time, we have over 20 genes that we're aware associated with this bone marrow failure syndrome that has a predisposition for AML. This syndrome also comes with a number of clinical manifestations not related to the bone marrow in terms of dysmorphologies and other organ involvement. In about 30 to 40% of patients with Fanconi anemia, there'll be some type of other stigmata that are identifiable, obviously, but not all the time. And at this point, there are about 20 genes in this pathway that have been described in patients with Fanconi anemia or that are part of the Fanconi complex. And the diagnosis is made using chromosomal breakage study, usually diapoxybutane or mitomycin C, for assessing the sensitivity of chromosomes with a chemical break. Again, similar to the telomere syndromes, it's important to identify these individuals as they have therapeutic sensitivities, and it's important to be aware of in terms of thinking about donor considerations as some of these patients undergo bone marrow transplantation. So we've mentioned some of the overt syndromes, Down syndrome, the RASopathies, the bone marrow failure syndromes, and predisposing to different leukemias. Then there are syndromes that specifically predispose to leukemia, and it's not obvious that there's necessarily other parts to the phenotype. AML has been, was one of the first syndromes in identifying a specific genes related to leukemia on its own. And RUNX1 was in 1999 was one of the, if not the first gene that we learned about in predisposing to AML on its own. As time has gone by, we've learned that transcription factors, cell signaling genes, genes that play a role in protein-protein interactions, RNA helicases, when they're constitutional mutations, and these different types of genes can all predispose to AML, with that being the main clinical manifestation on its own. To the point where the WHO in 2016 added the addition to their classification schema of considering constitutional mutations as part of the classification for AML. So RUNX1 is an autosomal dominant cancer predisposition syndrome. The exact prevalence is unknown, but we're getting better at getting to the point where we will have a prevalence number as more and more sequencing is occurring. Almost all patients that are identified with a constitutional mutation in RUNX1 have thrombocytopenia, and have abnormal bone marrow precursors of their platelets that are identified through morphology. And patients tend to have a mild bleeding propensity. And this is noted from the time of birth, or from early childhood usually. And there's a risk for MDS AML, T-cell ALL, with a 35 to 40% lifetime risk of developing these diseases over one's lifetime. The average age of onset is in the early 30s, with a range from 6 years of age to 76 reported. Before Hugo cracked down on gene names, CBFA2, RUNX1 was commonly referred to, and is a synonym just to be aware of when this gene is being discussed. And there's a very nice study that was recently published in Blood showing an integrated analysis of around 400 patients for frequency of RUNX mutations, which identified 12 individuals with germline mutations, showing the most common second hit in these individuals was another hit in RUNX, ASXL1, or a copy number alteration in trisomy 21. RUNX1 does appear to require a second hit for it to, and there is a dosage effect to lead to leukemia. There's also a nice somatic characterization of individuals' other mutations occurring in cancer census genes for those with both RUNX germline mutations as well as somatic mutations. RAS signaling with NRAS was commonly seen in individuals with germline mutations, whereas for individuals with just somatic RUNX1 mutation P53 was observed in that group, but not in the group with germline RUNX mutations. Another leukemia predisposition syndrome, or AML predisposition syndrome, is GATA2, which can have a variable clinical presentation and has been very nicely described by Steve Holland and the group at the NIH and others, is an autosomal dominant cancer predisposition syndrome with a mean age of 29. Individuals often have a susceptibility to the HSV family of viruses and can present in a number of different ways, from viral infections, AML, MDS, to lymphedema as a presenting feature. So this is a rather heterogeneous disorder and is something that people should keep in mind when they're seeing a family with these types of immune deficiencies, and particularly if there are other people in the family with a similar story. DDX41 is another familial AML leukemia predisposing gene, which is a helicase gene involved in pre-mRNA splicing. Individuals with mutations in this are estimated to have a lifetime risk of myeloid neoplasm of 20 to 30%. This tends to be an older age of diagnosis for individuals in their 60s, still younger than the mean age of diagnosis for AML, but but older than others with predisposition to leukemia. The full spectrum of this is still being, I think, really learned. Lucy Godley's has done and is doing a lot of work on aggregating patient data for those who have germline mutations in DDX41. And the spectrum to this is still really evolving, and we're gaining a better understanding. In the pediatric world, this is not a gene that we have seen much of in terms of children predisposed to leukemia. However, there are anecdotally stories of a few children here and there that have been raised at conferences that are I think, soon to be described. Individuals with mutations in DDX41 and the germline tend to also have hotspot mutations, or recurrent mutations that are seen. And then there's a common second mutation that is seen with an arginine to histidine change at 525. This is also of importance in terms of thinking about therapeutics with lenalidomide. Let me just see how I'm doing on time. So I'm almost there. Anchor D26 is another leukemia predisposing gene, or AML predisposing gene, and this can present in a similar way to RUNX1. For this gene, there is an enrichment in mutations in the 5' UTR end, and is important to be aware of in differentiating between RUNX1, and also, again, important for donor considerations. ALL, we've learned a lot about in terms of leukemia predisposition in the last 10 years, and transcription factors that can predispose to it, specifically Ikaros, PAX5, and ETV6. The spectrum to these so far has really been limited to leukemia. However, again, the full spectrum, I think, will probably broaden as we think about testing these genes in other contexts and looking maybe a little bit more carefully and phenotyping some of the families that we're seeing. But so far, that they do seem to be, based on the limited publications out there, leukemia specific. I just wanted to make another point about Li-Fraumeni and how our use of next generation sequencing has expanded our understanding of this phenotype. In 2013, Linda Holmfeld described the genomic landscape of individuals with hypodiploid ALL, which is a very rare subtype of ALL, less than about 1% of pediatric ALL. But of note from that work was that half of that population had a constitutional mutation, or in the low hypodiploid group, of having a germline p53 mutation. So in terms of evaluating patients with hypodiploid ALL, it should be standard of care that individuals with hypodiploid ALL are assessed for Li-Fraumeni syndrome, given the rarity of it and the enrichment of this syndrome in that population. In terms of treatment considerations, and this is one of the last slides, just in terms of thinking, I think it's often mentioned that it's important to identify leukemia predisposed patients as it relates to thinking about donors, as many of these individuals will undergo a bone marrow transplant, to identify siblings that might also carry the same thing that are potential donors. But increasingly, it's becoming more relevant for therapeutic considerations as well as toxicities. I mentioned the role of immunotherapy for CMMRD patients and our evolving understanding there, as well as dosing of anti-metabolite therapy for that population. And for patients with telomere syndromes and Fanconi anemia, the importance of avoiding high-dose myeloablative regimens that can be associated with increased mortality. And as there's been more and more preclinical and high drug throughput screens done, we're learning more about potential roles of therapeutics for as this plays a role for some of the transcription factors. So in addition to the donor aspect of treatment, it's also important for certain sensitivity considerations, as well as some of the preclinical information that's coming out and how for N-of-1 studies it might be relevant. This is just to highlight that we can't really generalize in terms of having a constitutional predisposition being absolutely associated with a worse outcome. Historically, it has been for telomere syndromes because of a lack of understanding of how to treat patients. For p53, in ALL, it has been shown to be associated with poorer outcome, but for CBP alpha, that hasn't been the story. So there's different reasons why I think we have the understanding we do, and there's still a lot that we need to go back and have ahead of time in terms of thinking about how we're treating patients to best understand what their outcome truly may be. So, in summary, the importance of understanding predisposition relates to making a diagnosis, treatment, supportive care, donor considerations. I didn't get into screening for other family members, but that is also a consideration. And then cascade testing and family planning is also of importance in identifying these predisposition syndromes. So I'll end there.
Great, thank you so much, Dr. Walsh. And now I'd like to introduce our next speaker, Dr. John Greeley, who is professor of the Department of Genetics and the Department of Medicine, as well as the Department of Pediatrics at Albert Einstein College of Medicine. Dr. Greeley is also the chief of the Department of Genetics Division of Genomics and the director of the Center for Epigenomics. His presentation today is entitled Communicating Complexity to the Vulnerable, Overcoming Challenges of Returning Results of Genetic Testing. I'll turn it over to you, Dr. Greeley.
Thank you, Katrin. Thank you to the organizers for this opportunity to speak today. This is an unusual talk for me to give because it's something that I should know about, because I have the dual roles of being a clinical geneticist and a pediatrician, but also somebody who studies genomics as my research program. But I've never had to give a talk about genetic counseling. And this is the link that's going to bring together the work that Dr. Versoy is going to talk about tomorrow in terms of the genetic testing. I want to talk about how we communicate these results to families. So I've been having to learn about the history of the field of genetic counseling and where we could be going as a field, and how we are going to have to be facing certain challenges as the field evolves over time in this new era of high throughput sequencing. So Let's start off with the history of genetic counseling. It was nice to see Dr. Walsh talking about history in his presentation. I love the way that we can figure out where we are on the arc of history, and it makes us understand where we are going. And the history of genetic counseling, as with the history of human genetics, is rooted, unfortunately, in eugenics. In 1941, there was an institute founded at the University of Minnesota based on a philanthropic gift by a very eccentric and eugenic-oriented individual called Dite, who lived in a treehouse and was involved with pushing legislation to sterilize people in state institutional homes. A kind of repulsive sounding character, but he gave this money to the University of Minnesota so they could form an institution with the explicit goal to promote eugenics. And eugenics at the time was not thought of as something particularly unfortunate, even though obviously Nazi Germany was about to be exposed as an abomination. A few years after the foundation of this human genetics department, it was taken over by this person, Sheldon Reed, who was actually, while he would have described himself as a eugenicist, he actually had some pretty redeeming qualities. And he recognized the value of forming a field that he called genetic counseling. And the three requirements that are listed as shown: you had to understand human genetics to be a genetic counselor. You had to be sensitive to the patients or clients, as he describes them. And you need to provide as much insight as possible for the patients that they were serving. Likewise, in what is currently modern Wake Forest University, there was an odious character called Colonel Wycliffe Draper, who gave the equivalent to what we $650,000 today to prove the superiority of the white race, but it was in the guise of setting up Department of Medical Genetics. And as you can see, the kind of quotation attributed to the first director of this department is completely unacceptable today. The history of these human genetics departments was that they were largely non-medical individuals. There were people like people who would study mice or fruit flies or whatever. And the counseling that they provided was generally very directive. You have this risk, therefore you must not have a family. That was basically how they were set up. And it's of note that even though the lessons of World War II and what was happening in Germany would at this stage have been known, they weren't really taken on board. The pivot happened at the end of the 1960s, obviously a time of civil rights and the equality and respect for people's autonomy and so on. And a very inspiring character at the Sarah Lawrence College, which is a women's college here in New York, Melissa Richter, decided that this was an ideal career for young women. And that it did not need a doctoral degree to be effective. It should be modeled on the medical social worker and could be taught as a master's course. In fact, some of the early training that was provided to these young women who were, Sarah Lawrence is not too far away from the Bronx, was in the institution where myself and Uli Steidl work, Albert Einstein. While initially Melissa Richter described the benefits of genetic counseling in terms of the elimination of birth defects, which had a eugenic ring to it, she was really trying to push the idea that this would be something which would be, as I say, based on medical social work and would be something that would serve the patients and their needs. And increasingly, there was a reaction to the idea that this field was set up based on eugenics. And so the idea of non-directive counseling, or in other words, allowing the patient the autonomy to make their own decisions, became the standard for the field. So genetic counseling today involves a number of different things. I won't read the definition that is still used by the National Society for Genetic Counselors, but you can see that it is quite a wide mandate for my genetic counseling colleagues. And what they would do typically in a patient encounter is evaluate the family history, figure out the risk that was involved for the genetic condition, provide as much education as they could, support the psychosocial needs of the family, plan for the medical options that might be available to the family and address all of the ethical issues. And this is a very time-consuming process, and this is one of the issues that we have to start thinking about. What are these ethical issues? Well, there are standard issues that have to do with all areas of medicine, and they're shown at the top. There's some issues that are particularly high flashpoints for genetic counseling, such as reproductive decision-making and the testing of minors. And as I say, as a reaction to the history of eugenics, the standard approach has been to be non-directive, value neutral, and not imposing your own views on the patient, allowing them to have their own autonomy. But we've heard from Dr. Walsh's presentation that we now have this explosion of sequencing-based approaches, and this is pushing us towards something that I'm going to circle back to at the end, the idea of evidence-based recommendations. So what is the risk assessment that we have traditionally done in this field? Well, before we could do genetic testing, which is within the careers of some of the more senior people like myself, I'm afraid to say, we would either say that the condition was sporadic and it was unlikely to recur in a family, or if there was a family history that was informative, we could say you need to have 2 carrier parents, and therefore it's a recessive condition, and therefore your recurrence risk is 25%, and so on. Or if it was a relatively common disease like autism or cleft lip and palate or something where you saw lots and lots of individuals with the condition, you could observe what the tendency was to have another child. So for autism, if you had your first child was affected, there was an increased chance of having another child that was affected. And if the first child that was affected was a female, then there was a higher chance of having a second child affected. And if you had 2 affected children, your risk went way up. And similar kinds of calculations we're offering for cleft lip and palate. But this is in the absence of knowing the genetic mutation. So now that we have genetic sequencing information, we get 3 types of results back. And you'd think that there'd be just 2, positive or negative. And positive means that there's something wrong with the gene and it's likely to cause the disease. And that's an important point to make, because we all have genes that have something wrong with them. And but very few of them are able to be linked to the condition that the individual presents with in the clinic. So for example, I would have a lot of genes with mutations in them, just as everyone else does. But unless I present to a clinic with something like a seizure disorder, it's very difficult to make a link between those genes and my condition. Negative results are generally useful, but we also have this category of inconclusive results, and I'm going to get back to this because this is something which is causing some perturbations in our field. It's also important to recognize, and this is something that you see all the time in clinic, that your idea of risk and your patient's idea of risk may be completely different. You may think that a 1 in 4 chance, a 25% chance of having, say, another child with a condition is very, very high. But for a family, that may actually be a relatively low, trivial risk. And likewise, a 1 in 1,000 risk may be completely intolerable for a family. So it's one of the early lessons that we learn in genetics, not to make any assumptions about risk, because risk is highly personal. The type of result matters. As I said, a positive result is generally helpful. A negative result is not always helpful. And a great example of this is when 23andMe started to offer BRCA1 and BRCA2 testing. And they only test for 3 mutations. So if you get a result back, you've got a family history, you're worried, you went to 23andMe and you got a negative result. Yeah, that's reassuring because they're looking for 3 relatively common mutations. But there are over 1,000 other mutations that have been documented for BRCA1 and BRCA2. So you may have false reassurance. You may think that you're not at genetic risk because you got this 1 test back that said that was negative. So this is, there's this surprising issue of negative results not necessarily being helpful. And the variant of uncertain significance, which is, it looks like it could cause the disease, but we just don't have enough evidence to push it over the line and say it's definitely causing the disease. This is a complex issue for both providers and patients, and it's something which is contributing to health disparities because people from, for example, sub-Saharan Africa have much higher diversity of their genomes, and they're much more likely to have variants of uncertain significance as a consequence. So we're underserving certain populations based on their ancestry. It's also important to recognize that we're dealing with very vulnerable patients. You tell somebody that the reason that, say, their child has a condition is because you've found a genetic mutation. All of a sudden, you've locked in that this is not going away, that it is something which is going to be, the child is going to have to live with their entire life. And that can remove any hope that the family has that this is only a temporary issue. So for others, it's a positive thing. They know that there's something going on. They know that it's going to be there long term. And it's great to have an answer, but we have to be aware of the fact that we could be really causing distress when we give these results. Guilt, you see it all the time. A father or a mother or a grandmother or something like that realizes that they passed on a mutation to their children and their grandchildren. And the guilt that you can feel from that is extreme. Also, if your multiple siblings get tested for, say, a BRCA1, BRCA2 mutation, RUNX1 mutation, and some people have it and others don't, the ones who don't get it can have this almost like an equivalent of survivor guilt. So we have to be attuned to that as well. There's clearly blame and anger. You know, your brother didn't tell you that he had had genetic testing and didn't impart that information, or did tell you and you didn't want to know. So families can get really sundered by this kind of information. And you know, you know that you have a genetic risk of an adult disease. How do you ever get back to a baseline level of not being concerned? There are a lot of areas of vulnerability that we have to be aware of when we do this kind of genetic testing. However, a big issue is that as we do more testing, we're going to need to have more counseling. And right now, there are some opportunities and concerns in terms of how we're putting out our genetic counseling workforce. It's a very female-dominated field at the moment, and it's in part because of that history that I described. And it's wonderful, we're getting really talented women involved, but we may not be getting all of the talented men in that could help to bring up our numbers still further. It tends to be whiter than the American population and less fluent in more than one language than the rest of the US population. And if we have a situation, there's a picture of people in the Bronx where myself and Uli Steidl work. If we are serving a population which is Spanish speaking and has grown up with limited education in some situations, for example, has a very different life experience, with all the goodwill in the world, somebody like myself cannot make a connection fully with a family like that. So having people who are able to empathize more fully with our population is definitely going to be a plus for the future. As we do more testing, we have more problems with the return of the results. So I've talked in terms of BRCA1 and BRCA2 as if we're testing for maybe 1 or 2 genes, and that was typically what we would do a number of years ago. But now we can sequence the entire genome as part of our provision of services to our patients. And as well as getting the result back for the diagnostic indication, why does the patient have leukemia? Why does the patient have a seizure disorder? We can also look at the medically actionable genes, the cardiovascular risk genes, the cancer risk genes, other genes, where we can actually do something if we find a problem. And about 2 to 3% of the time, we will find something which can change a family's life. We can do carrier screening. We can see if there's any risk of administration of certain drugs. So lots of a new area of polygenic risk scores, which is quite complex. The more we can find, the more information we could be imparting to the family, and that's going to increase the burden on what we need to be able to provide as services. Genetic testing is moving beyond pediatrics, prenatal obstetrics, oncology, to newer fields like internal medicine and so on. So this is adding further challenges. And when a genetic counselor is doing their job well today, they're generally spending quite a long time with the family, including with things like with the emotional support of dealing with the questions and concerns and the vulnerabilities that I described. So if we're going to scale up to provide all of these services, we either need to have a huge number more genetic counselors, or we need to start having them work more efficiently and effectively. So one of the solutions that I've been involved with is this thing called GIA, developed as a collaborative effort with Mount Sinai, ourselves, and the New York Genome Center. And this is an electronic means of providing information back to families. It involves clever data visualization and accessibility So it's designed to be simple enough that it's very intuitive, but as you'll see on the right of my slide over here, we also have it so that the results can be returned to the patient in Spanish. And in fact, we have multiple different kind of dialects or common usages of Spanish that we can attune to the patient's upbringing. So to bring it to the loop to a close and talk about RUNX1 specifically, let's think in terms of this family here. You've got a grandmother who died. You've got her 2 sons affected, and then there's a granddaughter who's also affected. This illustrates all of the issues. It looks cold and factual, but if the grandmother realized that she had passed this on to 2 more generations, you can imagine how she would feel in terms of being distraught. You can imagine how these sisters here feel knowing that their brothers are at risk. This father here is wondering whether he's going to survive long enough to look after his 4 kids. This is the human side of genetic counseling that we are having to deal with what are pretty lengthy interactions. If you look at the variants that have been found in the RUNX1 gene, above the protein structure here are the ones that are pathogenic, the ones that we know cause disease. Below are ones that are benign, because you can have changes in the DNA sequence that don't cause problems. But all the red arrows show are the variants of uncertain significance. And the variants of uncertain significance, we don't know whether they should be below or above the line. Perhaps some of these actually cause problems. So how are we meant to deal with these variants of uncertain significance? Well, we're actually told that we should call them negative. But because they appear on the report, and because, you know, as physicians, we're not always well attuned to making judgments about what appears on a report, we will often end up telling the patients, physicians and genetic counselors will say, there's something here that is concerning to the lab. And what has been found in the case of BRCA1 and 2 is that this will often tip the family into overestimating their risk of cancer, especially if people are coming from a more limited educational background. And this has actually led to an increase in women having their ovaries removed and their breasts removed, for example. So we have got to carry out our responsibility as physicians to use this information as part of our diagnostic process, but at the same time avoid taking information which is inherently not really, we don't really know the significance of it, and have people overinterpret it because of concern. So there's an educational issue there. So this is kind of pushing us to an evolution of genetic counseling towards this evidence-based counseling, where we start to tell the patients, listen, we can't educate you enough. We're going to tell you that you should perhaps downplay this variant of uncertain significance. We start to impose our own values. And this is where the complexity of what we're trying to do is getting harder and harder all the time. And we need to make this accessible because otherwise we're going to be propagating health disparities. Future challenge beyond all of this, all of the variants that we are currently looking at that are known to cause disease are in the protein coding sequences of the gene. But if you look at the gene and the genome, you have all of these areas which are being flagged in this particular representation, which sit around the gene. And these are the loci that probably switch the gene on and off. And it's quite possible that in some of these loci, changes in the DNA sequence are going to start to be associated with risk for hematological malignancies. And the complexity of trying to describe that is going to be yet another challenge. So I'm going to close with a special thanks to my genetic counseling colleague, Caitlin Brown, from whom I learn a lot. And I think myself and Dr. Walsh will both be happy to answer questions.
Yeah. Great. So thank you so much, Dr. Walsh and Dr. Grilli, for these fantastic talks. And so we will open the discussion. I want to remind everybody, if you have questions, put them in the question and answer box. We have a few already. And, you know, I'll start with a couple for Dr. Walsh. So the The first one is from an anonymous attendee, and it's similar to a question that I wanted to ask. And the question is, it appears that germline RUNX1 mutations largely show hematologic manifestations, but not many other systemic ones. Is that related to the expression pattern of RUNX1, question mark?
Yeah, I think so. It's one where in the families that have been looked at to date, the rest of the clinical information that has been aggregated hasn't supported it predisposing to other disease. So yeah, that seems to be the reason that you mentioned.
Great, great, thanks. And if I can add on like a small question in the broader syndromes, that can manifest in different organs. Is it not, with different penetrance and site preference? What's known about the triggers? Why a broader syndrome manifests in one organ versus the other? Is there much known about it, or is it pretty much random, or is it co-mutations, somatic mutations, infections, different things? What's the view on that?
Probably a combination of all of those things that you mentioned. If you take trisomy 21, you have an entire chromosome gain, which is a lot of gene real estate, if you will, that could be playing a role in a number of different biologic downstream pathways. For other general predisposition syndromes that are involved in DNA repair, the organs that seem to be vulnerable, one of the main ones is skin, and which is under constant bombardment, requiring DNA damage repair. So I think it's a combination of all of the things that you said, and why the different organs are involved.
I just wanted to make a quick comment, if I could, that there is an ongoing natural history study of RUNX1 familial platelet disorder at the NIH under the direction of Dr. Paul Liu. And it's clear, at least preliminary evidence suggests that there may actually be other organ systems that are being affected by germline RUNX1 mutations. So we're hoping that that data will be coming soon, but it does appear that it is not purely a blood disorder. And so time will tell with more patient numbers.
Paul was on the webinar, so he's listening as we talk about it.
Well, if you want to say something, you can say something.
Sorry, I didn't do that justice.
Well, wait until the symposium in November. We'll tell you the secret.
Yes.
Nice to see you, Ross.
Thank you for the plug. Please join us at our conference. All are welcome.
That's great. Yeah, that was a prepared question, right, Katrine? Okay, now we'll move on to the next question. Actually, I think it was answered in the chat already, but I'll ask it again because I think it's interesting for the broader audience. And it's a question by Vivian Chang. A great talk. What is the best approach for interpreting telomere length results in the setting of residual leukemia present in blood, especially if there's a VUS in a telomere disorder gene?
It's tricky. I mean, the nice thing about the telomere genes is the fact that there is this functional assay with flowfish. It's in terms of interpreting those results in the context of disease it's difficult. I think that the approach would be often to see if the disease segregates in the family, and then assessing the telomere lengths of others in the family as well, which is probably of more help for the dominantly inherited telomere syndromes than others. But it's a problem in terms of interpretation, and the setup of the flowfish assay. It's been replicated twice now. Once in Vancouver with Repeat Diagnostics, and now with Mary's group at Armanius at Hopkins. And these subpopulations have not really been studied to answer that question.
Great, thanks. And the next question by Jude Fitzgibbon. could you outline the journey that a patient follows in your clinic if during an initial consultation a query of familial myeloid malignancy is made? What are the steps if there are no obvious lesions detected in the known loci?
Sorry, I missed the question. Was that for me or for some? I missed that.
Yeah, it's for you again. And could you outline the journey that a patient follows in your clinic in an initial consultation, especially if there's no obvious lesion detected in the known loci? That was for myeloid malignancies.
Well, so it depends on the patient, and if they're the clinic I have is one where we see patients predisposed to all of the different malignancies, so both solid and liquid tumor. For a myeloid malignancy, when patients come to us, they might be in the throes of treatment. So the first priority is their treatment, and in terms of understanding the heritable part of it and getting it the predisposition, we will do a skin biopsy to have a pre-test counseling session, explain to them our understanding of leukemia, go through the family history in detail, and then for AML patients, we pretty much do universally evaluate for malignancy when they're referred to our clinic, given that those that tend to present to our clinic are on the younger side, and it entails usually sending a skin biopsy for sequencing of the known AML leukemia predisposition genes. And we do flow fish and chromosomal breakage in the appropriate setting. In some instances, in particular, the case that was just mentioned, it can be difficult to interpret what those results may or may not mean if they have active disease or they've recently been treated. But we do try to get that information as well, gather the family history. It can take quite some time to get the sequencing results back because the fibroblasts have to be cultured, the DNA has to be extracted, and then to generate a report in a CLIA lab, that can take a month. So once we have those results back, we bring back the patient to review what we've learned. And if the testing is negative and there is a strong family history, we try to enroll the family in a study for we have a general gene discovery study at Memorial for understanding cancer predisposition syndromes, and depending on one's interests, they may or may not participate in that. And the goal is to try to find an answer, but that's obviously a difficult thing to do in many instances. But we do try to continue to follow families where there seems to be an enrichment in the family, and make sure that the usual suspects for the leukemia predisposition genes are ruled out.
Great, thank you. And maybe one quick, somewhat related question before we pivot, I think, to Dr. Greeley in the interest of time. But Aditi Shastri from Einstein actually asks, again, this is for Dr. Walsh, last question for him. What's the coverage of commercially available myeloid panels of heritable mutations? Which commercially available panels or academic-based panels do you recommend using if we suspect a familial syndrome based on family history?
Yeah, so the labs, University of Chicago has a comprehensive myeloid leukemia panel. And their panel also includes the ALL genes. Memorial has the panel. We're in the process of CLIA validating that and moving in the direction to having it in-house ourselves in the CLIA manner. Cincinnati has a rather robust panel. There were a couple of other companies that people may be familiar with that are no longer, that were at some pretty good institutions. But we tend to send it to Chicago. In some instances, we'll send to GeneDx, depending on insurance coverage for the individual.
or Cincinnati.
Okay, great, great. Thank you so much. So a few questions for Dr. Greeley. So first of all, John, that was a fantastic talk. I've never hear you give that type of talk before, so I learned a lot. It was really fantastic. And I saw there were some comments in the chat already, people, you know, sharing my enthusiasm for your talk as well, and you responded to some of them. The one thing I wanted to ask is, you know, regarding to the reference genomes, if you will, or the databases. I mean, you had this one slide where you nicely compared the, you know, some of the disconnects kind of between the counseling and the target, the patient populations, in particular in the Bronx, just in terms of language and gender and et cetera. You know, I was wondering, I mean, this VUS, or when you call something a pathogenic mutant, that must be a numbers game as well, right? And I'm just wondering, to what extent, or what is the percentages of reference genomes that are, you know, applicable to the different ethnic and racial subgroups, and, you know, how does that match the patient population? I would, you know, anticipate it's pretty poor in the Bronx, for instance, but can you give like some approximate numbers or comment on that issue as well?
As of the early 2000s, something like 90% of genome-wide association studies have been performed on Northern European white populations. It was grossly biased. With the recognition, with activism by some of our genetics colleagues, and with the recognition of this as an issue by the National Institutes of Health, there's been a real push to find out what is normal in terms of DNA sequence in populations from other ancestries. There's never enough that we can do to understand that. We'd have to sequence every population, because every population has brought its DNA to New York City, for example. We have got to understand a Pakistani as much as a Laotian, as much as somebody from Samoa. So we can do that, though, and that's actually relatively simple. The question becomes, are there certain populations where what you're trying to do is to see, is something relatively common in a population, in which case that change is probably not causing disease, unless it's something which in that population, the disease is unusually high. And we all know about things like sickle cell disease and people from various malaria endemic parts of the world. In Ireland, if you are positive for hemochromatosis, as I am, as a carrier, that's almost like getting a genetic test saying you're Irish. And it's a high frequency, but if you know that you're Irish, you know that it's associated with the disease, because you know what the prevalence of the disease in that population is. So it's a mixed challenge. The challenge is to sequence enough people, but also to understand what diseases certain groups of people are prone to. And we're getting good at the first part. We still have a long way to go with the second part, and it is an important part of health disparities.
Mm-hmm.
Can I ask, in line with that topic around sequencing different ethnicities, especially if you're using a commercial panel, for example, is there any sort of operational or process in place that allows for the so that you can actually take the VUSs and put it into a repository? Because I know that ClinVar has done an excellent work in sort of starting to mine the RUNX1 germline mutations, but it just brought to mind that there's probably, how do we make sure we don't miss all this sequencing data that's being done by commercial laboratories?
I'm guessing that Dr. Bersoy is going to talk about this tomorrow,
Okay.
but ClinVar is the central repository for all of this information, and that is great. There's more that we could be doing. You know, we only get to send all of the testing to ClinVar, and if we're not testing everybody, then ClinVar is going to have a skewed representation of our population, and that is the case. And we're also we're putting in a lot of variant information, the DNA sequence information, without a huge amount of information about what the patient actually looked like, which is relatively limited. So there's more we could do, both in terms of what we do with the individual patient and also in terms of representing the population more equitably. But the structure's in place, and it's hopefully a matter of time and accessibility to genetic testing.
And John, maybe one more quick question.
Just to follow, I was just going to.
Oh, sorry. Go ahead, please.
No, I was just going to say, to follow up on that question, because it's an important question about the data aggregation. There are different efforts going on, and ClinVar, of course, is a terrific effort, and with ClinGen and the effort that Lucy's been leading with the aggregation of the RUNX data, as well as now the other leukemia predisposition syndromes. There are the CBio portal at Memorial, the PCAN database at St. Jude, and there are other efforts being put in place with the commercial labs. So there's a collaboration between Harvard, Memorial, Mayo Clinic, and Penn called PROMPT, which is the Prospective Registry of Multiplex Testing, which is an effort to try to capture the variants of uncertain significance that are being generated by the commercial labs. And the commercial labs that are participating in that are Invitae, GeneDx, Ambry. I don't know if they were at one point, as well as a couple others, but related to this topic, Chicago is not involved in that, nor is Cincinnati. So there is an effort on the pediatric side to try to create another version of PROMPT through the pediatric lens, and a lot of pediatrics is leukemia. So that's a lot of rich and well annotated data that's being generated at a CLIA level. But that's just something to finish out on that point, because that is a very important point around data aggregation and knowing what's out there already.
Great, thanks. My quick question, or hopefully quick, is what's the coverage of the non-coding genome in our assessment of variants, both at a technical level, but then also at the prediction and analytical level, because obviously there it's much more challenging.
Well, it's a situation where we're surely missing things, because the data that we have has been generated in different ways, and it's been done in some instances. It's been generated from capture panels, and in other instances it has been generated from whole genome sequencing, and then in other instances it's being done in one-off of genes that are being tested in certain situations. So the different studies and universally assessing patients is something that there's much to be desired. And as it pertains to clinical testing, clinical labs for the most part are testing hotspot alterations that are known pathogenic, or they'll call things that are frame shift splice mutations or truncating alterations that are obvious. But in many other instances, their calling algorithm for what they may report back might not include some of the missense variants or synonymous changes at an exon junction that does disrupt splicing, that could be doing something. And as the ICROS story has shown us for ALL, that's potentially problematic, because while many of the predictive algorithms are calling some of these variations harmless through the in silico models, when you functionally actually do look at them, they do cause some disruption of some sort. So the coverage question is one question, and then how things are filtered is another, and then the universality of how patients are evaluated are all real issues in terms of getting to your question and really understanding the landscape as we would want it. Myeloid is nice in the sense that it's ahead of some of the other disorders based on the work at Memorial and at WashU and elsewhere, but commercially, a lot of this has not followed suit.
Great, thank you. Yeah, I'm looking at Katrine and have an eye on the clock. I think and fear we have to wind down in the interest of time.
Yes, I think we do. But I want to just end and close by saying thank you so much to Dr. Walsh and Dr. Greeley, and of course you, Dr. Steidl and Dr. Levine, for being here with us and moderating. And I hope you all join us tomorrow at the same time. for another great session. So thank you very much. Have a good evening, everyone.
Thanks to you and to the foundation for doing this. It's really great. So we'll see everyone
Absolutely. Thank
tomorrow.
you.
Thanks again to John and Mike.
Thanks for
Bye-bye.
having me.
Absolutely. Thank
Thank
you
you,
all,
everyone.
and see you tomorrow.